Or in French?
Moi, je fais mon intervention en anglais.
En anglais, okay, but both languages are welcome, so don't worry. So I wish to wish you a good, a warm welcome for this press conference about Ebola outbreak in DRC state of play with Dr. Joanne Liu and Mr. Ousmane Sene, who will speak about this important topic from Médecins Sans Frontières. So before to give you the floor, I would like to ask you to sign our golden book. Just here. Yeah. It's not a check, it's just a signature. Don't. And after we will open the floor for the conference. Dr. Sandler. So, Mrs. Liu, you have the floor. You will be starting the presentation. Yeah. Okay, thanks. Oops. And just push the button for speaking. Please, you don't need to. It's better like that. Don't worry.
Non, mais moi, je préfère comme ça.
Oui, mais vous allez tirer le fil et ça va arracher le micro.
J'ai toujours le dernier mot.
Je vois, mais...
C'est comme ça. Bonjour tout le monde. Merci d'être venu. Je vais faire mon intervention en anglais. Je suis très heureuse, je remercie ici la maison de nous avoir invités, de nous permettre de faire cette conférence de presse. Et je remercie à mon collègue, Dr. Ousmane Sene, qui était le médecin qui était en charge du centre de Butembo, au Nord Kivu, qui se joint aussi à la conférence de presse. Donc, on va commencer avec un énoncé en anglais, une intervention en anglais, et après ça, il y aura une période de questions-réponses. Vous pouvez parler soit en anglais, soit en français. So we're going to start the conference. We're going to start with a statement. And then after that, there's going to be a Q&A. And then Dr. Ousmane and I will be more than happy to answer your question. I have just returned from DRC, Democratic Republic of Congo, where people are facing the biggest Ebola outbreak in the country's history. 907 people have fallen sick from Ebola. 569 of them have died. While I was there, 2 of our Ebola treatment centers in the epicenter of the outbreak were attacked. We were forced to suspend our operation in those areas. How did it come to this? What is clear is that there is a great hostility against the whole of the Ebola response. In the last month alone, there were more than 30 different incidents and attacks against elements of the response. It would be all too easy to place the blame on the communities themselves, or to say that they are not complying with the public health measures. But the problem is not the community. It is our collective responsibility to gain their trust and empower them to take ownership of the response. The existing atmosphere can only be described as toxic. It shows how the response has failed to listen and act on the needs of those most affected. There is a deep contradiction at the heart of the response. On the one hand, we have tools and innovation that previously we only dream of. there has been a massive mobilization with resources on the ground. More than 80,000 people have been vaccinated, and new therapeutics are being used. And yet, despite all this, the signs are that Ebola is not under control. Why? Why? Because within 7 months, all the indicators are not normal. More than 40% of the deaths are right now taking place in the community. That means that we have not reached them and they have not sought our care. 35% of the newly infected people are not known to a chain of transmission, meaning we don't know how they got it. Late presentation for care of those infected means that their treatment would be far less effective. That means that Ebola still has the upper hand. This epidemic is happening on the background of political, social, and economic grievances. This is a region that has been hard hit by armed conflict. For decades, violence and neglect has made North Kivu a place where even common ailments can be deadly without adequate care. Malaria, watery diarrhea. And now, we have a situation where donors are pouring millions of dollars into an Ebola response, while people feel their suffering has been neglected for years. After all, what is it that the local villagers sees of the response? They see fleet of cars, they see fleets of cars driving too fast, having to take away a single sick person. They see vast amounts of money pouring in, but they don't see where it ends up. They hear the constant advice to wash their hands, but nothing about the lack of soap and water. They see their relatives sprayed with chlorine and wrapped in plastic bags, buried without ceremony. Then they see their possession burnt. Many of those with a negative view of the response feel that Ebola is being used as an excuse for political maneuvers. These suspicions were only exacerbated following the decision to exclude Beni and Butembo from the election at the end of 2018. People told me Ebola robbed me of my basic democratic right. We must acknowledge that this outbreak is occurring in a deeply politicized environment. Patience must be placed before politics. Ebola responders are increasingly seen as the enemy. Some local health staff have told us that they live in fear of being associated with the response, fearful of reprisals from the community. The use of coercion adds fuel to this. Using police to force people into complying with health measures is not only unethical, it's totally counterproductive. The communities are not the enemy. Ebola is the common enemy. The use of security forces and police only deepens the suspicion of those who feel that Ebola is being used as a political tool. So, what needs to be done? In a sense, the effectiveness of this Ebola response will rest on whether or not it is viewed as legitimate and trustworthy. Today, what reason does the population have to trust us? To fix this response, we must ensure we are looking from the patient perspective. Ebola is a brutal disease. It brings extremes of isolation and suffering. Doctors, nurses cannot even touch their patients. We must be honest. The offer from the Ebola Treatment Center is not a very tempting one. Away from your loved ones and surrounded by strangers in spacesuits. Until there is a more tempting offer, can we really be surprised that many still prefer to remain in the community rather than staying in treatment center away from their families? If we are to change that, the response must be shaped about their concerns, not ours. In practice, what does it mean? It means that community is a partner. It means that the patient is a partner. It means establishing viable community-based care for those who do not want to attend treatment centers. It means providing vaccine for more people. It means training people within hard-to-access areas so that people can protect and care for their own families. It means treating patients as humans and not as biothreat. And in turn, that means integrating Ebola care into the wider healthcare. It means listening to people's needs and not preaching to them. And certainly, it does not mean responding with increasing force. The Ebola response has so far failed to build a humanized response, and we all share responsibility for this. Again, let's remind ourselves, Ebola outbreaks start in the community and stops in the community. Thank you very much.
Thank you, Mrs. Liu. So now I would like to give the floor to Dr. Usman Sem for some details. And yeah, please. Yeah.
Good morning. Je vais faire mon discours en français. S'il y a des questions en anglais, je vais essayer de répondre en anglais. Moi, j'étais le project medical referent. J'étais le référent médical du projet de Butembo. La situation qui s'est empirée au cours de notre séjour, c'est qu'on a constaté qu'il y avait beaucoup de résistance et que, par ailleurs, il y avait beaucoup de militarisation qu'on a remarqué. Cette situation s'est détériorée et que ça a amené brûlure du CTE de Katwa et après de Butembo. Je ne vais pas faire un autre discours, donc la présidente a déjà fait un discours. Je vais peut-être attendre vos questions et s'il y a des éclaircissements à faire, donc je vais le faire avec la présidente. Merci.
Merci, merci. Bah, j'ouvre tout de suite les questions. Peut-être juste, moi j'en avais une. Est-ce qu'on peut chiffrer un peu où on en est en termes de malades, d'étendue, de géographie, etc. Parce qu'on sait qu'Ebola, il y a plusieurs pays qui sont atteints. Est-ce qu'on a des données plus précises ou pas, Sos?
Pour le moment, on a seulement une épidémie qui se passe dans le Nord Kivu. Donc, il y a plusieurs... L'épicentre a bougé de différents endroits, a commencé à Mangina au début. Après ça, s'est déplacé sur Beni. Et maintenant, elle est plus au sud, dans la région de Katwa-Butembo. Mais on parle seulement d'une épidémie aujourd'hui au Nord Kivu.
Et ça concerne combien de gens? Enfin, potentiellement, c'est... Disons, pour le public qui ne connaît pas forcément tous le Nord Kivu par cœur, c'est combien il y a de population qui pourrait être touchée, combien?
Donc, il y a plusieurs millions de personnes. Si je me rappelle bien, vu que je suis canadienne, je me rappelle que c'était plus ou moins la taille du Québec, de 6 à 7 millions de personnes. Mais notre inquiétude aujourd'hui, c'est qu'il y a l'épicentre qui est à Butembo. Goma n'est pas très loin et on sait que c'est une population de millions de personnes. Donc, c'est aujourd'hui, on a une inquiétude parce que vu qu'on n'a pas la vision, la photo globale, parce qu'on sait qu'il y a un grand pourcentage de décès dans la communauté, on sait que les gens qui se présentent aujourd'hui sont pas non plus partie de chaîne de transmission. On est extrêmement inquiet que ce que l'on sait est plus grand.
Yes. Yeah, in English it would be much better actually, because we've got people from Nairobi that are actually following right now, and other places in...
Yeah, you can speak English, no problem.
Good.
No, it's... but French and English are both languages that can be used. Yeah.
2019.
It's up to the speakers, yeah. So another question, yes, please, Mrs.
Lisa, yes, Lauren. Okay, let me try to figure this out. Oh, okay. Hi, Lisa Schlein, Voice of America. To tell you, I'm frankly shocked to read in your press release about the coercive measures that you talk about, that police and armed forces are compelling people to go to treatment centers and to have their loved ones buried without any kind of ceremony. And you talk about the mistrust in communities, and I understand that. But I have had so many, really, a lot of interviews with the Red Cross and with others and so forth about how they try to build trust in the community, so that I'm quite shocked to hear that there's this total lack of sensitivity, or that the work that they are doing is not working. And so I'd like you to respond to the coercive measures. And then a second question is, how do you get, there are many armed groups fighting in North Kivu and Ituri province, and they come from the communities, but how do you get through to them in terms of the critical aspects of the Ebola epidemic and what needs to be done in order to control this? Thank you.
During our stay there, because I was there 2 times, at the beginning of the outbreak and at the end, as you know that we left there. At the beginning, we were not seeing many militaries. But at the end, yes, we were feeling that there is a lot of militarization of the Ebola response. I will just give you one example, because one day they called me and told me that there is a patient who was coming in our ETC, Ebola Treatment Center. I said yes, it's a patient, because the patient was coming with a burgomaster who was a leader of the community. He was one of the Ebola response team. I said yes, it's okay, but no militaries in our ETC, okay? And for me, it was a patient. It was a suspected cases validated by the investigation team, but it was not that. It was not a suspected cases. It was a brother of a suspected cases. And I said, what a brother of a suspected cases are doing in our ETC? It was something that was saying that we couldn't understand a non-suspected cases come come in our ETC, and for that we said in our coordination meeting that how can the militaries bring someone who is not a suspected cases in our ETC? Because at the end, the patient was inside our ETC. And if it's not a suspected cases, you shouldn't be in. That was one of an example of the militarization. the militarization took one person who was not a suspected case inside our, bring him inside our ETC. And it's something that we did not understand, and we protest of that in our coordination meeting, and it was a total mess for the right of the person that they bring, and also for our right to treat only suspected cases or confirmed cases.
I'm sorry, you know, I find this confusing. That is, you're saying it's the government military that are interfering with the treatment, going into your treatment centers. Are they putting spies in there? I mean, was this brother a spy, or did you ever find out why this person was there? It sounds so crazy to me.
Well, let me just bring, you know, some nuance to this. Basically, it's just there's been some events where people basically were brought up either by the police or either by other the other authority figures to the center, and then they were tested in our center. What we're saying is, like, we think that people need to come, you know, with their own will to be tested and as well to be treated, and we need to do that. We have worries, especially that right now we are painting the Ebola epidemic as a security emergency. This was said, you know, in the press conference yesterday of the Ministry of Health in DRC, and they say that it's not right now. They frame it as a issue of public order. We think, as physicians, that it is an epidemic, an infectious disease issue, and that we need to treat patient and not, you know, I would say, enemy, you know, of the nation. So there's something, you know, that needs to be reframed, and we know deeply, because we've been, and all of the actors have been, that Ebola brings fear, but we need to not succumb of having as a tool an increased, I would say, securitization of the response. People need to feel that we are with them and we want the best for their care, and then that they want to be in our center because they believe that's going to be the best way to fight Ebola. And that's what we need to restore. We need to restore the faith of what we have put forward so far. And then what I was trying to say is the fact that we have incredible tools. We were craving for that in 2014, 2015. We were craving for vaccine. And today the vaccine is there. But it's a vaccine that only, you know, vaccinate the contact of patient, the contact of contact. The population do not understand why they don't have access to that vaccine. So we need to explain, you know, there's a lot of things that needs to be explained, but we need more vaccine, and we have other, you know, vaccine right now in development. We do hope it's going to be put, you know, forward, you know, for and be reached, to be used, you know, for the population to protect the spread of Ebola across North Kivu. But it's about, you know, when I said it's about having community as partner, patient as partner, is there's not many disease where somehow a patient is totally deprived of his decision making. And all of a sudden, you're labeled with Ebola and you don't have no choice. You are put somewhere isolated, you are all of a sudden being cared by people with spacesuit, and you don't have a say. Well, we're saying if we want to get the trust of people, then they need to be able to just say that they want that. And if they don't want that, we need to be able to give them another option. That's what we need to do. And we're all responsible to that. And we're taking our part of responsibility, MSF, to not basically, you know, translate that in very much tangible. But today, you know, we've got the wake-up call. We heard it. You know, patient want other option. Patient want to understand. And patient want to own their disease. This is not something that is falling upon them. They're part. It's like, I always say, I'm a doctor. And when I have a patient with a disease, like a bad disease, you know, because we have to compare it to something bad, like leukemia. I have children. We know that, you know, good part of the good outcome of healing a patient is that he's going to be part of his illness, of his healing. And then right now we're not doing that. It's very important. That's what we're learning. So I don't want us, to get hung up on those things. It's just today there needs to be a real, I would say, because right now the new buzzword is community engagement. Everybody talks about community engagement. That's very sexy. Okay, but what does it mean, community engagement? And this is why we need to fix that. It's not only to talk to people and preach them, but it's to sit and listen. What do you want? You don't like, to be put in Ebola center? Okay, so what can we do? You want us to pay attention as well when you have malaria? Yes, we're going to do that as well. You don't like the fact that we're going and burning your belongings in your family because someone was sick? Okay, how can we do that with you? How can we talk about that? How can you be part of that? You don't like, that we are taking care of the body of your family where they then put them in a plastic bag and you want to be part of that? You should be part of that. This is all the things, we need to address in a concrete way. It's just like we've given a lot of labels about, enterrement digne et sécurisé. But we didn't translate it in tangible thing that for them, it was dignifying and respecting their tradition.
I also asked you how you get through to the various armed groups who may be coming from the communities but are fighting a war. How do you get through to them to explain Ebola, the dangers of Ebola to them?
Well, we do it wherever, like we do everywhere. We work in conflict zone. MSF work in 71 countries. 60% of our work is in conflict zone, and we talk to everybody. And what makes a difference of the way we're able to carve a place for ourselves is to have medical intervention that is pertinent for them. That is, our trading token. That's what we do everywhere.
Yes, please. Please speak at the microphone for the video. Yeah. Okay.
Nina Larson, AFP. I was wondering, you suspended your participation in these two centers. I was wondering, what will it take for you to return? Are you planning to withdraw completely from the country? It would be interesting to know that. And also, during the big outbreak in the West Africa outbreak, MSF was very critical of the World Health Organization's very slow response. How do you think the World Health Organization has responded to this outbreak? Do you think, you're criticizing the dignified burials, that they're not as dignified as they should be. This is something that the WHO has been boasting about. So it would be interesting to know what you think about that. Thanks.
Thank you very much for the question, and actually it's to give me the opportunity to clarify that. Actually, Democratic Republic of Congo for MSF is a country we've been intervening for decades. And we have a wide footprint, in the area. And right now, in some area, we vaccinated more than 350,000 people for measles outbreaks. So it's of the 71 countries, DRC is one of the top 3 country of deployment for MSF. So no, we're not pulling out from DRC, that's for sure. What is real is we are, right now suspending our activities in Katwa and Butembo, but in the region, we're still there. We're still there in Kaina. We're still there in Lubero. We are still there in Beni, in Bunia, and Komanda. So we're there. And then we are right now readjusting the way we're responding to having this sort of more global approach to health, give him other options to patients when they are being tested. This is what we are doing. So yes, in terms of the response, I think that yes, it is indeed that we had some critical words for the WHO in the past. I think that now everybody is massively deployed, but we're taking it from. I always said that Ebola is a very, very, very humbling, I would say, type of disease to tackle, because we repeatedly don't get it right, and then right now we have a massive deployment, and yet we're still being challenged. So I think that all of us need to readjust. And then to a certain extent, we're almost saying that the response, some aspect of the response are almost out of control to a certain extent because there's so much stuff going on. There's so many cars driving around. And then the committee are like, why are there are so many cars driving around so fast? And why, I'm still have my child dying of measles in my home? People don't understand what is going on. There's a perception issue as well.
Yeah, please.
So just from the two centers that you have suspended your activities in, what would you need to return there? Do you need guarantees that the military or police will not be involved in any way? What are you in negotiations to return, or have you withdrawn from there?
The return, right now we're still reflecting, but we still as well, I've started some discussion. But the thing is I think that what we realize is being part of this whole machine of response might not have served us as well as we thought. And we think that in many other places, we actually treasure MSF. Somehow that sort of space that is neutral and independent. And then what we would like to do is to basically carve out that space for us to work, where there would be no forces. But we do understand, there needs to be some sort of security disposal for sure. But where we're going to work, we hope that it's going to be free of that. That's what we want to find. Carve a medical humanitarian space that would be free of that sort of disposal of security inside or just in front of our center. That's what we hope for. We don't know if there's going to be that space, but what we're discussing. And we need as well to make sure that the community want us back, first and foremost. People need to want us back. And maybe you want to add something on that, because we had a long discussion yesterday, Usman and I.
I think that what we want really is to have a good engagement of the community. If we have a good engagement of the community, and community is different part. The military, they are inside the community. The population, civil population, they are inside the community. All the population, if we engage and we understand really the Ebola response, I think that it will be really good. And we will be really free, and also we will hope maybe to return. It will be a good point.
Okay, oui, je t'en prie.
Good morning. Tom Miles from Reuters. I have two questions, please. You mentioned people don't understand, why the vaccine has to be done in this ring vaccination way, and it's not available for mass vaccination. Do you blame Merck, or is there somebody who should answer some questions about why this vaccine hasn't been fully licensed, which I understand it's kind of on the brink of, and that would enable a bigger vaccination campaign to go ahead. And second question is, what scenarios do you see for the epidemic, the outbreak, for the rest of this year? I mean, is there a chance that it could end? Is there a chance that it could blow up enormously? Or I guess both of those are chances. What chances do you see? What sort of likelihood do you put on the various scenarios? Thanks very much.
Thank you very much for the question. We can always count on Reuters for good question as well. All right. I think the ring vaccination is really good question. And I don't think we're beyond, a blame game. But the reality is we want more tools. And then what we know about that vaccine, that we have from Merck, it's a vaccine that we use in a reactive way. It's basically someone has been infected, and we use that vaccine for in a prevention way for the contact and the contact of contact. This is massively what is being used for, and a bit in a preventive way for what MSF has been doing in terms of vaccination for a healthcare worker, what we call the frontline worker. The thing is we know that there is a limited amount of those vaccines, and we know there is other vaccine in development, and we do hope that we're going to be able to put at disposal those other vaccines in development soon. we know that there needs to be some regulation and some specific things that need to respond to, but we need as well other tools in terms of vaccination, and we know they are out there. So we're playing for this to be put at disposal soon. In terms of scenario, I can give it a try, but I don't have a crystal ball, and I think that right now, knowing that 40% of the people who are confirmed are dying in the community, at least for the one we know about, and knowing that 35 to 40% of the people who are confirmed do not belong to the chain of transmission, meaning that we don't know where they get it, it's really hard for us to come with any prediction at this stage because we don't have the global picture. And so that's what I can say. But the thing is, I am not sure, and this is why we are being, and I'm taking from the humble take that we're not sure that if we keep doing what we're doing, will lead us, to the end of things. I always make that joke in my office about my favorite definition of insanity. It's to keep doing the same thing and hoping for different results.
Thank you. Other questions? Vas-y, oui. Faut que tu trouves un micro sans le... Voilà, juste appuyer sur le bouton.
Yeah, I just wanted to know, Paula Dupont, yes, Iran News. I wanted to know whether there's been anyone who's been arrested, or the people who are responsible for those attacks, whether there's been any follow-up. Do you know who those people are? And then secondly, also with these attacks, what has the response from the workers themselves been? Has it been difficult to keep them, or are there any issues with finding new volunteers to help with you?
So I'm just going to start. In terms of who are the perpetrators of the attack, we don't know. So that's the answer. So right now we're still, analyzing, reflecting, but we don't know. And no one has taken responsibility for it.
Okay.
For the second question, the staff, the national staff, are already started to work with WHO and the MSP at our ETC in Butembo, but still in Katwa they are closed. I think that there is two scenarios. That's why they are continuing to work, because they need to work to gain money and to solve their problem, but also they don't have choice. It's their population, and they need to continue to work. But the problem is now they are treating the staff. They are treating the staff to say that if you continue to work, I will do something bad. They are continuing to work. I don't know if it will be like that for long time, but still the problem that they are not comfortable really to work, but they are still working with WHO and MSP.
Okay, thanks. Yes, microphone, please.
Antoine Weber, an ex-ICRC and Red Cross staff over half a century in many situations. And my main question relates to the awareness of the population at large about the deadliness of the disease. In fact, it's a huge threat to the whole part of that country, and everybody should welcome measures to treat the people who get sick and to protect the people who are not sick. And I wonder sometimes whether we, if we intervene heavily, as outside relief organizations, are not part of the problem. It's in fact difficult to understand for a simple man in the village who has never got the health care he needed or she needed, and then to see this over-investment in a struggle which is justified. But if the awareness of the deadliness of the disease is not spread with everybody, and so the people don't understand why so much means are used for a number, maybe at the beginning a limited number of patients, we get those clashes. And I wonder whether, in addition to MSF in that region, there are other agencies who are active, who are not facing this problem, because the relationship with communities, of course, the main factor. But yeah, now MSF, who is a kind of holy organization in our minds, is facing such problems. Is it unique, or are other regions better off when it comes to the struggle against Ebola? Sorry, I was long.
Yeah, you were long.
But this is the major.
No, I just want to come back to your awareness, and I just want to make sure that we don't paint people as if they do not understand what is going on. Communities do understand what is going on and do understand there is Ebola. And then the reality, just to take a simple example, is when the election didn't take place in December, they make their own election and they make their own system of washing their hands and making sure that nobody would be infected. So they get it. They get it. It's just what is the reality is there's some, the way we are responding to it and the option that we're giving them when they are either suspected or infected is not appealing. For example, I was there. Someone, is suspected. Then what happens to when someone is suspected? You go to what we call a transition center. And then what happened is someone already, start to talk to them at arm's length. And then they're going to get a first test. And then they're going to be put in a sort of a room on their own. And then they're going to have to wait to have a second test to make sure that they're not positive or negative. Is there any other way to do that safely, but not this way? They don't like to be, for 48 hours somewhere. And then as well, they might have another helmet. They might have we've treating some of their medical element, but it's just not, conducive and attractive right now. So they understand what's going on, but the thing is as well, we need to offer option that is agreeable to them. We need as well, to listen to what would be agreeable to them, because I know that they probably do have some answer. And right now, in Kaina and Lubero, we are doing basically, I would say, a readjustment of how we are addressing Ebola with the community in the healthcare center with them. So that's what we're doing.
Okay, thanks. So maybe last questions or comment or intervention with our distinguished speakers? No? So, in this case, thank you very much. Good luck for your struggle against Ebola, and wish you the best. Okay. And we can have a coffee if you wish to have a direct talk with Mrs. Liu and Dr. Sen. Okay, thanks.